Hi everyone, my name is Stephanie Griffith and this lecture is entitled Fluid Stewardship and Why It Matters in Septic Shock. My disclosures are that I am a Principal Medical Science Liaison in the Critical Care Division at Baxter. This lecture has been approved for one continuing education credit for nurses. Our learning objectives for today's lecture are to understand what fluid stewardship entails and its foundational principles. We're going to discuss the clinical importance of why fluid stewardship matters in the treatment and management of the septic shock patient. We're going to explore evidence-based strategies based on the research and best practices for effective fluid management in various patient scenarios, focusing on dynamic assessments of fluid responsiveness to guide those fluid decisions in your critically ill septic shock patient populations. And we're going to go through a literature review looking at real-world data showing us the value of stroke volume guided fluid management as you're taking care of your septic shock patient. All right, so let's go ahead and get started by defining fluid stewardship. So for decades, fluids were viewed as benign, right? A harmless water-like intervention. For this reason, as well as others, fluids have been given without a strict dosing range, and static pressure parameters historically have been used to guide fluid administration decisions in the hemodynamically unstable patient. Fluid administration is a cornerstone treatment for patients in septic shock. That's not typically debated. What is debated is how much fluid a patient in septic shock needs. So this brings us to the concept of fluid stewardship, which is a framework designed to treat fluids with the same respect as any pharmacologic intervention. So you're balancing the benefits and the risks, adapting treatment to each patient's evolving condition, and knowing when to start and knowing when to stop. Antibiotic stewardship is built on principles like diagnosis, drug type, duration, and similar principles can help us guide fluid use. The authors of the review article, Principles of Fluid Management and Stewardship in Septic Shock, it is time to consider the 4 Ds and the 4 phases of fluid therapy, engage us in a discussion around how if antibiotic stewardship is built on principles like diagnosis and drug type and duration, then similar principles can help us guide fluid administration as well. So the 4 Ds of fluid therapy are drug, duration, dose, and de-escalation. So drugs. So fluids should be treated as medications, requiring a thoughtful prescription, just like our medications like vancomycin or acetaminophen, that sort of thing. Dosing. Precision is vital, and it's achievable using dynamic assessments, and we're going to talk a little bit about that today. Too much or too little fluid has consequences. We're aware of that, and we're going to dive into the parameters we can use at the bedside to maybe tighten up our fluid administration and help it be more precise. Duration, so therapy should be discontinued when hemodynamic stability is achieved, and de-escalation, stopping or adjusting therapy is as critical as starting it. So the parallels when antibiotic stewardship is applied to fluid stewardship, you've got overuse, so too much fluid administered leads to volume overload, for example. Misuse, consequences of fluid choice. We're going to talk about the difference between balanced solutions versus normal saline. Underuse, inadequate fluid resuscitation, for example. Let's just really quick define stewardship, because I think this definition, if we keep it in the back of our mind, will be helpful to us as we keep going. So Merriam-Webster defines stewardship as the careful and responsible management of something entrusted to one's care. So while this concept is very central to antibiotic therapy, for example, it's now being applied to fluid administration because we know that administering IV fluids is it's not without risk. And thinking of fluids as drugs feels a little counterintuitive at first, but I think it moves the conversation to focus on a framed and evidence-based approach that clinicians are already familiar with, right? And they can very easily apply it because they're already familiar with it. And as we move toward precision medicine more and more, this idea of individualized care for every single patient, these principles of fluid stewardship will really help us refine our approach to fluid administration. So as I often say, this gives us some fluid for thought. So we talked a little bit about the why on the previous slide, but in patients with septic shock, hemodynamic stabilization using intravenous fluids remains a major therapeutic challenge, as numerous questions remain regarding the type, the dose, and the timing of fluid administration. So we should only prescribe fluids when they're clearly indicated and should balance the risk of not administering enough with the increasingly apparent risks of too much fluid. So again, throughout this lecture, we're going to examine why fluid management isn't just about giving more or less, but about precision dosing, about timing, about individualizing the patient's care, which also brings us to what the authors, Dr. Malbrain et al., in that review paper talk about, which is the 4 phases of fluid therapy. And we're going to unpack this a little bit later, but just at the beginning of the lecture, I want to mention the resuscitation phase. They outline the Rose model. So resuscitation, so obviously the rapid fluid administration to restore circulation. Optimization, which is tailoring the fluids to maintain organ perfusion. The stabilization phase, minimizing additional fluids as that shock is actually resolving. And de-escalation, so actively removing excess fluids to restore fluid balance is something that they suggest. And it's an incredible paper. I really recommend you read it. It gives you a lot of fluid for thought, and it also will help you approach fluid maybe with a different paradigm. We want to be delivering the right fluid and the right dose at the right time for the right patient, and that is what we are pursuing. So the primary goal of fluid stewardship is about the 4 Ds of fluid therapy, and it's also about the 4 phases of fluid therapy, and really as we care for our patient across that full continuum of care. And as we look at that primary goal of fluid stewardship, just to reiterate, we want to optimize the type, the amount, and the timing of that fluid to ultimately improve patient outcomes, which is why we're here. All right, so the FDA defines a drug as a substance recognized in the official pharmacopoeia or formulary that's intended for use in the diagnosis, cure, mitigation, treatment, or prevention of disease, and as a substance other than food intended to affect the structure or function of the body. Okay. So by this definition, and by definition that a nurse cannot administer IV fluid without a provider order, we're aware that IV fluids are technically considered to be medication. So it's not so much that clinicians would consider IV fluids to be something other than a medication or a drug. It's just that the amount of IV fluid given makes it seem like the dose of them is less important than other medications. So we simply don't have a hard and fast rule for the dose of IV fluid the way we do, say, acetaminophen, for example. Furthermore, the consequences of giving too much fluid do not immediately manifest in our patients. So the causal relationship between IV fluid and AKI, for example, can be really underappreciated. Additionally, giving too little fluid can also result in all of these physiologic consequences for our patients that can be very life-threatening. So it's a challenge. It's one of the most challenging medications, honestly, to administer. And oftentimes when I'm speaking with clinicians, they express that. They express wanting to be more precise and really appreciating additional parameters that can help them guide those fluid decisions. So whether or not to give fluid in the early phase of shock or in the presence of hypoperfusion isn't really the part of this conversation that's up for debate. I'm aware that there is IV fluid administration is a widely controversial topic, and it's widely debated, and it's not, again, that these patients who are hemodynamically unstable maybe don't need fluid. That's not really the question. The invitation from the literature and from clinical practice is that if we fully consider IV fluids as drugs, then it opens up a pathway for us toward greater precision in our approach to IV fluid administration. And so within the context of fluid stewardship, that we have the opportunity to look at drug type and dose and duration the way we do with other medications, which is extremely helpful to us. So let's talk a little bit about if fluid is a drug. Choosing between, crystalloids and colloids. A quote from the article that I found very interesting was, "We must always bear in mind that fluids are drugs and edema is akin to a drug overdose." Edema for many years was considered purely a cosmetic consequence. It was considered benign and not necessarily an issue with that third spacing or even anasarca in our patients. And we now know that is actually not the case. So let's discuss just briefly normal saline and balanced solutions. Just for the sake of time, we will leave off. Well, let's talk about the two fluids that are primarily used for the sake of time with fluid resuscitation in sepsis and septic shock: normal saline and balanced solutions. All right, so when we consider the fluid choice type of fluid, if you will, I want to look at the Surviving Sepsis Campaign guideline recommendations. So for adults with sepsis or septic shock, we suggest using balanced solutions, balanced crystalloids, instead of normal saline for resuscitation. So why is that? Let's talk about the difference between normal saline and balanced solutions. So the key issue, well, some people are calling normal saline. I've heard physicians call it abnormal saline and nurses call it abnormal saline at this point. But the key issue with fluid resuscitating in sepsis and septic shock with normal saline is the chloride load and the creation of the hyperchloremic metabolic acidosis. So normal saline has a supraphysiologic chloride concentration in it, which can cause that hyperchloremic metabolic acidosis by increasing the chloride levels in the blood. So this can reduce the body's ability to, regulate its own pH, and it leads to acidosis and vasoconstriction and decreased renal perfusion. Now, obviously, in the septic patient, there's that renal injury risk, and so the increased chloride load can decrease the renal blood flow and contribute to AKI, that acute kidney injury. Specifically in this patient population, that's something that we really do want to stay away from. So the benefits of balanced solutions then, as we consider that, balanced solutions contain buffers that are metabolized to bicarbonate, so it helps neutralize the acid. And obviously, they're in a septic shock patient, you're already in an acidotic state, so that helps neutralize the acid and maintain a normal pH, which prevents that hyperchloremic acidosis, hopefully, in those patients with normal saline. So multiple studies. Where are we getting this recommendation from, or why are we getting this recommendation? So multiple studies, including the SPLIT and SMART trials, have shown that using balanced solutions instead of normal saline can help reduce the incidence of AKI specifically, and the need for dialysis in ICU patients, which is enough of a reason for many providers to choose balanced solutions as opposed to normal saline. Now, again, you have to looking at the full clinical picture of the patient and other things going on. So again, I'm not being prescriptive. I'm offering up summaries very briefly of literature. As always, please check with your provider, follow your institutional policy, look at your literature. Diving into this is a Herculean effort, but it is worth it. So again, we've got this this idea that using the balanced solutions can reduce that AKI, protect that renal function, because in septic shock, the kidneys are already vulnerable due to that hypoperfusion that is going to be present. So if we can reduce the AKI or additional potential for AKI because of that hyperchloremic acidosis, then again, that's why you'll often see providers pursuing balanced solutions for fluid resuscitation. In the SMART trial, they found that ICU patients who received balanced solutions had lower composite outcome of death, dialysis, and persistent renal dysfunction compared to those who received normal saline. In other studies, they say there's no mortality benefit in the balanced solution group versus the normal saline group, and that it doesn't matter. So again, I would do a deep dive in the literature. There does seem to be some pretty solid research behind the idea of the balanced solutions, again, being better in the environment inside a septic shock patient as opposed to normal saline. So in patients with, if you're trying to correct metabolic acidosis, in patients with metabolic acidosis due to sepsis, the balanced solutions can potentially help correct that acidosis faster, right? Potentially improving that tissue oxygenation delivery. So this one can, just like fluid, again, you can sense some of my hesitation to not be prescriptive, to offer you what I'm reading in the literature, and if you read the full text of the 2021 guidelines and really try to understand and discern why they're making this recommendation, this is some of where it's coming from, just as a review to pursue balanced solutions as opposed to normal saline in when you're looking for the fluid of choice. And when we are treating fluid as a drug, as we are, you know, we're already thinking through the indication, right? Shock, the dose, how much, and then the side effects would be, for example, if we choose normal saline, then the side effect might be the hyperchloremic acidosis that comes with the large volume administration with the fluid resuscitation. So hopefully that is helpful to you in terms of a breakdown of a discussion around why your provider may be ordering a balanced solution as opposed to normal saline. And most likely you're already seeing that institutional change or change at the institutional level. And again, looking at the individual patient and determining what they need is just part of the complexity of caring for these patients. All right, so let's move on and talk now about fluid dosing. So this quote from the article I thought was profound. Like other drugs, it is the dose of fluid that makes them poisonous. As stated before, the risk of excessive fluid overload is well established. So we know that fluid is an independent risk factor for mortality. So this idea of dosing fluids to patient response is going to be made possible by a dynamic assessment. And so you've got your fluid responders and your non-fluid responders, and you can actually determine which patient is a fluid responder by doing a dynamic assessment of fluid responsiveness, which we're going to really dive into. So when you are pursuing dynamic assessments, there are different ways to do a dynamic assessment, and there are different parameters that you can actually, dynamic parameters that you can look at. And so what we're going to do is we're going to talk about the difference between dynamic versus static parameters, and then we're specifically going to look at stroke volume index or stroke volume index % change in response to a small fluid challenge as our parameter of choice in this particular lecture. But before we do that, I want to remind us of what's actually going on in the body in septic shock, because our treatment is predicated on the pathophysiology, and it's really helpful to kind of dial it back for just a minute and level set. This, I know, is a gross oversimplification, and it's something you already know, but it does help us remember why we're doing what we're doing. So we have infection, which creates inflammation in the body, and we know that the primary source site of infection for sepsis is the lungs, which is why, or the respiratory tract, which is why you're going to see rates of septic shock rise during flu season, for example. So you have infection that creates inflammation, that releases the vasoactive materials and toxins into the blood, that makes the vessels vasodilate, and fluid leaves the vessels again. Completely gross oversimplification here. This is why, though, we are doing the fluid resuscitation, and we are also in a shock state, in a refractory shock state, often needing to replace the vessel tone, which is where you get the vasopressors from. Pressure drops if we are not intervening, or sometimes even if we are, let's be honest. And then heart tries to compensate by increasing the heart rate, so you see that compensatory tachycardia. And then as fluid continues to leak, cardiac output is not enough to meet the basic metabolic demands of the body. So again, in remembering what is going on pathophysiologically, we now look to the treatment, and we see Surviving Sepsis Campaign guideline recommendation for patients with sepsis-induced hypoperfusion or septic shock. We suggest at least 30 mL per kg of IV crystalloid fluid be given within the first 3 hours of resuscitation. So this is also, we get that recommendation, and we know we have the CMS core measure for SEP1 with the weight-based fluid. I'm not going to dive into all of the literature around the weight-based fluid. I know some people are for it and some people are against it, and so this isn't an attempt to try to solve that conversation. And I want to be really honoring and respectful of every single patient's individualized volume need, as well as the need for fluid administration in patients with septic shock. This is why this is so tricky, is because we know patients need fluid, and the amount of fluid, again, is the most widely debated part. It's not, does the patient need fluid? It's how much fluid does the patient need? So we want to fluid resuscitate the patient, and usually to a certain endpoint goal, which is for the sake of argument, let's say you did the 30 mL per kg, and then your patient, you will check to see, are they hemodynamically stable, or are they not, right? Are they still hypotensive post-weight-based fluid, essentially? And that's really where a decision-making point often comes into play. So we all know that there are consequences, again, with over and under fluid resuscitation. If we don't give our septic shock patient enough fluid, they're going to be hypoperfused. And if we give our patient too much fluid, we might send them into a volume overload state. So what the literature shows, this is the Bellamy curve, is that every single patient has an individualized volume need. And we also know from recent studies like Classic and Clovers that a one-size-fits-all approach, like fluid restrictive versus fluid liberal, those are the one-size-fits-all approaches that they were looking at, does actually not have a mortality benefit. So in other words, every patient has an individualized volume need. And what this study shows is that when you actually target the middle of the curve, in other words, giving the patient exactly what they need, no more, no less, and this is also known as the Goldilocks principle, right? That your patient has a better outcome, and that fluid overload specifically is associated, again, with worse outcomes, which you've heard me say before. So the question then becomes, well, how do you actually target the center or the middle of the Bellamy curve? How do you actually approach this? And so we have another recommendation here. For adults with sepsis or septic shock, we suggest using dynamic measures to guide fluid resuscitation over physical exam or static parameters alone. And the reason we're getting that recommendation is because pressure-based parameters are what we have been using historically, whereas flow-based parameters like a dynamic measure, where you're dynamically challenging the heart with fluid and then observing the heart's response to that fluid, actually has data behind it that improves patient outcomes. All right, so let's talk about what a dynamic assessment is. The relationship between stroke volume and preload is described by the hyperbolic Frank-Starling curve. When the heart is operating on the steep portion of the curve, stroke volume increases substantially when preload increases with intravenous fluids, which means administration of fluids improves cardiac output and oxygen delivery. So the clinical challenge is to determine whether an individual patient's heart is operating on the steep portion of the Frank-Starling curve or the flat portion of the curve. So essentially, a dynamic assessment is challenging the heart with a small amount of fluid and then observing the heart's response to the fluid while looking at stroke volume change in real time. The next question I think we need to ask ourselves is, when we think about dynamic measures, or what's the difference between dynamic measures and static measures, and why can't we just bolus the patient with fluid and see if the blood pressure goes up? And that's a really good question. So there's a difference between pressure and flow. So let's talk about this study. In 1944, these volunteers were bled until they fainted. And this has since been replicated in healthy subjects with using lower body negative pressure suits, shunting blood from the torso down to the lower extremities, simulating acute blood loss. So, but this study is interesting since we don't bleed people until they faint anymore. But I do want to talk to you about what is going on in the body in terms of pressure and flow. So you'll notice that cardiac output, they start bleeding the volunteers, and cardiac output falls early and it falls linearly, right down in a straight line. We see blood pressure dips a bit, rebounds, and then just falls off a cliff when they faint. And we see the compensatory rise in both the systemic vascular resistance, which we would expect, and the heart rate. So we would expect that the heart rate is going to climb, and we know that the vessels are going to clamp down. That's just compensation going on in the body. Notice, though, that cardiac output, it falls early, and it falls linearly, and it doesn't rebound. So cardiac output changes before blood pressure. So pressure and flow are not equivalent. Blood pressure, there's just a difference between pressure and flow, as you know, and the biggest issue and the biggest problem with blood pressure is the resilience of it. Our bodies are designed to hang on to blood pressure no matter what. And so your body, or your patient's body rather, will compensate and compensate and compensate and compensate until eventually they crash. So what's really helpful about looking at cardiac output or stroke volume, which if stroke volume, notice that the formula for cardiac output, if you were going to write it out, is cardiac output equals heart rate times stroke volume. So as heart rate climbs, it mitigates the drop of cardiac output, or hopefully softens it a bit. As that heart rate climbs, it helps compensate for the dropping of the cardiac output, which means stroke volume is, while impacted by heart rate, is slightly less impacted by heart rate. And again, that's, I'm sure, an oversimplification, and I respect that. I think for the sake of time, I'm trying to just be clear. But it is helpful to be looking at cardiac output or stroke volume. So cardiac output's the overall amount of blood pumped by the heart in liters per minute. Normal is, 4 to 8. A lot of units prefer to look at cardiac index because it's more patient specific. It's your normal divided by your body surface area. So a normal cardiac output is 2.5 to 4. A normal stroke volume is what's the volume leaving with each stroke or beat of the heart. So you've got heart rate, which is how fast your heart's going, obviously, and then you have stroke volume, which is the volume coming out with each stroke. So a normal stroke volume is the same range as normal heart rate, 60 to 100, and then roughly half that is your stroke volume index, 33 to 47. And so why I'm saying that is because if you're trending your stroke volume index, for example, and it begins to drop, that should raise questions for you about, is there a developing or worsening perfusion problem going on in my patient's body, even if the blood pressure isn't changing yet? Because again, your cardiac output and your stroke volume will change ahead of blood pressure. The other thing to note is that we have been using historically static pressure-based measures like blood pressure or CVP to help us guide fluid decisions and I'm not suggesting we stop looking at blood pressure. We still do see CVP used to guide fluid decisions, although it is not a predictor of fluid responsiveness, and that has been pretty well documented in the literature. CVP tells us a right atrial pressure measurement, and it can be very valuable. So depending upon what's going on with your patient, if you need that right atrial pressure measurement, then you need to transduce your CVP. But in terms of telling you volume status, it's not as accurate as we want it to be. It's not helpful as a dynamic measure, certainly, but in terms of overall volume status, it's just not as helpful as we want it to be, which now we know from the studies and from the literature. And so really that's why there's suggestions from Surviving Sepsis to move toward dynamic as opposed to static measures to guide those fluid decisions. You want to challenge the heart with a little fluid and then observe the heart's response to the fluid and determine where that patient is living on that Frank-Starling curve. So for my novice nurses out there who might be new to critical care, you probably remember your nursing professor may be explaining the Frank-Starling law of the heart like a rubber band. So the more stretch you have on the rubber band, the more snap you have. But if you overstretch the rubber band, the rubber band becomes flaccid, it becomes weak. And the heart operates, and again, that's a simplification, but the heart operates with a similar principle. And so you don't want to give fluid ideally to a non-fluid responding heart, because if they're on the top portion of the curve, then that would be a heart that is considered having less strength of a contraction, for example. And blood pressure cannot tell you that. A blood pressure cannot tell you if your patient is a fluid responder. Just like a CVP can't tell you if your patient is a fluid responder. The only way to determine if a patient is a fluid responder is to actually dynamically challenge the heart, looking at a dynamic parameter and seeing if there was a change, for example, in stroke volume, which we're going to continue to unpack. So before we continue the discussion around what a dynamic assessment is and how do we actually do it to determine or help us determine a dose of fluid for our hemodynamically unstable patients, I want to take a look at the KIND study. So the KIND study was published in 2024, and it was the Knowledge of Intravascular Determination study. And essentially, I want to just read to you from the article itself. So there's a difference exists between a patient's volume status and their body's ability to respond to fluid therapy, i.e. fluid responsiveness. Volume status refers to the volume of blood circulating in the intravascular system. Fluid responsiveness indicates an increase in stroke volume of 10% to 15% after administering a fluid bolus or a physiologic bolus with a passive leg raise. We're going to talk about that. Clinicians frequently confuse the two, which contributes to inappropriate clinical management. So let's look a little bit more into this study and why it matters for us. All right, so let's dive into the KIND study just a little bit more. So the Knowledge of Intravascular Determination study aimed to understand the knowledge of frontline RNs regarding fluid status and fluid responsiveness and the use of associated technologies. So there were 44 states that were represented in this survey. And so let's look at some of the statistics that we have here. 89.7% responded that having an accurate measurement of volume is important. 96.2% said it's important to know both fluid status and fluid responsiveness. 63.9% said volume status is difficult to accurately assess in their current work environment, and only 30% of nurses said they have some kind of technology that they use to guide fluid management. So one of the conclusions from the authors was that a knowledge deficit exists among nurses regarding the understanding of hemodynamic and intravascular fluid status and monitoring, and that nurses in all clinical areas are still relying heavily on traditional inaccurate monitoring. And so let's look at the most common parameters that nurses are currently using to guide fluid decisions. All right, so the assessment parameters that are most frequently used by nurses to assess volume status of their hemodynamically unstable patients, if you guys see on that bar graph all the way to my left, urine output is the number one parameter that nurses are using to assess the volume status of their hemodynamically unstable patient. So when I say hemodynamically unstable, just in case you haven't read this particular article, they're usually defining hemodynamic instability as hypotensive on a vasopressor. Maybe they're tachycardic in some kind of a wicked AFib, maybe with RVR. They're with blood pressure changes. So urine output actually is the first thing that we're looking at. What's interesting about urine output, of course, is that it changes last. So it's the very last parameter that will change in a patient who's exhibiting signs and symptoms of a perfusion deficit. The first thing that will change is stroke volume. It's just that we're not monitoring stroke volume. Oftentimes in the early phase of shock on our patients, and so we wouldn't be able to see that unless your patient was crumping right in front of you, of course, and you had hemodynamic monitoring on them looking at their cardiac output and stroke volume. You're going to see tachypnea before you're going to see tachycardia, and you're going to see tachypnea and tachycardia before you see hypotension. And then eventually the urine output will drop. And again, all of that's just the compensatory mechanisms in the body. So why is this helpful for us? This is helpful for us because oftentimes nurses are advocating for the administration of additional fluids, and they're the ones also titrating their pressors. And so really when it comes to fluid stewardship, this idea of fluid stewardship and this idea of fluid dosing, your nurses are your frontline clinicians who are helping to determine fluid boluses and whether or not a patient would be fluid responsive. It's going to be the nurse most of the time that in many of the units, at least that where I have taught, that are actually doing the dynamic assessment. And so really understanding what common practices or what current practices helps us just kind of level set to say, okay, this is what we're doing, and is there any room for improvement? Is what we're doing working for us? Are there outcomes that we want to pursue changing or improving, that sort of a thing, which is why the literature is so important. All right, so again, let's continue the conversation or the discussion around why dynamic measures instead of static measures. And we're going to walk through a study that is a meta-analysis that talked about which percentage of patients would actually increase their cardiac output in response to further fluid. So when I say further fluid, these patients had gotten fluid resuscitated initially, so think like weight-based fluid, all right? And then after that point, if they were still hypotensive, what this study actually showed is that only 50% of the patients were fluid responders. So let's break down what that means. So what meta-analysis showed is that only 50% of hemodynamically unstable patients were actually on the ascending limb of the Starling curve, and that meant that at that point in time, only 50% of those patients were maybe going to benefit from additional fluid resuscitation. So imagine this, you've done your lactate and your blood cultures, your antibiotics, and your weight-based fluid, and your patient is still hypotensive. That is an invitation to ask the question, well, does my patient need more fluid? Or they're obviously in a refractory shock. So now, do they need fluid, or do they need pressors, or do they need both? And the question for us of do they need fluid, when we go back to the principle of fluid stewardship and we think about the dose of fluid, we want to assess to see if the patient is a fluid responder, and then we can say whether or not they are likely to increase their cardiac output in response to further fluid. Why is this so important? Because 50% of the time patients will be fluid responsive, which means 50% of the time patients won't be fluid responsive when they're hemodynamically unstable. That's what this literature is saying. All right, so what can be used as a dynamic parameters? There are different dynamic parameters and assessments that you can do. So the Surviving Sepsis Campaign recommends dynamic parameters include response to a pacilized or fluid bolus using stroke volume or looking at stroke volume variation or pulse pressure variation or echocardiography. Just really quick, stroke volume variation and pulse pressure variation do require that your patient be intubated. According to the literature, most of the validation studies are done in patients who are intubated in normal sinus rhythm, and then breathing very specific tidal volumes and a set rate and different things like that. So there are limitations to those parameters, and when those limitations are met, those values are very accurate. Echocardiography is usually not done by the nurse. That is usually provider will do the echo. And there is a way to do an echo and a passive leg raise to determine fluid responsiveness. For this discussion, we're going to focus on using stroke volume or looking at stroke volume in real time, getting minute-to-minute data because it's very well studied. And we're going to talk about how to do a dynamic assessment using a passive leg raise or a fluid bolus. All right, so a passive leg raise is the most useful test for predicting fluid responsiveness in hemodynamically unstable adults. What's nice about a passive leg raise is that you're not introducing any additional fluid into the patient's system. What's hard about a passive leg raise is that sometimes your patients are too hemodynamically unstable to maneuver, in which case if you cannot do a passive leg raise like is shown on your screen, and we're going to talk about the steps here in just a second, then you can mimic a passive leg raise, which is essentially an intrinsic fluid bolus with an external bolus. So let's talk about what a passive leg raise is. So when you sit your patient up in bed at a 45-degree angle and you are monitoring stroke volume index continuously for 3 minutes, that's called getting your baseline. So when your patient is sitting up in bed again at a 45-degree angle with their legs out in front of them, the blood is pooling in their calves. And you're looking at stroke volume index continuously. So let's say you get a baseline of 20. So what the literature tells us is that a stroke volume index that climbs 10% or more is indicative of a patient who is a fluid responder. So this is all from the literature. And so when you get a baseline of the stroke volume index with the patient sitting up with their legs in front of them, let's say the stroke volume index is 20, and you lay the patient's head back and you passively, you don't want them to help you because you don't want them to squeeze their calves and increase their venous return. So you do want it to be passive, which is why they put it, I think, in the title just as like a reminder that the legs are elevated, and then what happens is you get that venous return that shoots up through the IBC and hits the heart really, really fast, actually. This actually happens much faster than I even originally knew. When I started doing this, I had no idea that a lot of patients will reach their maximum stroke volume index in 90 seconds or less. So it's very fast and it's very accurate. So the sensitivity and specificity is on par with other diagnostic tests that we use, like troponin. I mean, it's a really, really great test, very sensitive, very specific for telling you, hey, what did the heart do with this fluid? So again, this is a critical question we're asking ourselves when your patient is hypotensive after they've already gotten fluid. We know they're in a refractory shock state. We know from the other literature that fluid is only going to help patients at that point, at that moment in time, 50% of the time. And so we want to go ahead to, and if we can't tell by looking at the blood pressure, we want to go ahead and check before we administer further fluid, because if we don't check, we don't actually know. And we can't tell if a patient's fluid responsive, again, by looking at those other static parameters. Heart rate won't tell us, and urine output won't tell us, and other things like that. And so you can do a passive leg raise. So you get a baseline stroke volume index, and then you challenge the heart with a little bit of fluid. And then if the stroke volume index climbs, according to the literature, 10% or more, the patient is considered to be fluid responsive, which means they're likely to increase their cardiac output in response to 500 cc's of fluid, 500 mils of fluid. That's all from the literature. If a stroke volume index doesn't climb to 10%, so there's a cutoff, your patient is considered likely not fluid responsive, and that should raise questions for you about the value of further fluid at that time. Maybe they need a vasopressor. Maybe they need an echo to determine cardiac function. We know that sepsis-induced cardiomyopathy is very prevalent in septic shock patients. So when you are managing care of the septic shock patient, you're constantly looking at volume, you're constantly looking at the vessels, and you're constantly looking at the pump, volume, vessels, and pump. And so this really helps you determine what is going on with your patient in terms of the volume status, dynamically challenging that heart with fluid and observing the heart's response to the fluid. So as I said, you have to be looking at stroke volume index in real time because it happens so fast. So that's why you need to be using some type of technology that enables you to look at stroke volume index in real time. And again, you want something that's accurate in arrhythmias because AFib is so prevalent in these patients, as well as obviously tachycardia because they're hemodynamically unstable. Now, if you cannot do a passive leg raise for any reason, you can mimic the intrinsic bolus by giving an extrinsic bolus. So what you'll want to do, and this is also, these amounts are just from the literature, you would want to give 250 cc's in 5 minutes or less. Again, you want to challenge that heart with fluid and observe the heart's response to the fluid. You want to interrogate that Frank-Starling mechanism of the heart. And the only way to do that is to give a little fluid really fast. So 250 cc's has to get in the heart in 5 minutes or less, or 500 cc's in 10 minutes or less, which means you would need to follow your hospital policy for putting fluid on a pressure bag, because 999 on the pump is actually not going to hit the heart fast enough for it to be considered a dynamic assessment. So those are ways that you can do a dynamic assessment, a PLR or a fluid bolus extrinsically. Usually in a lot of institutions, if you're doing a passive leg raise, that can be nurse driven. But if you are doing a fluid bolus, obviously, most likely you would need an order because you're giving that patient fluid for that small fluid bolus to do a dynamic assessment if for any reason you cannot do a passive leg raise. All right, so you might be asking yourself, well, does using a dynamic measure of fluid responsiveness, does that approach, implementing that in clinical practice, does it change outcomes? And that is a great question, and the answer to that is yes. Let's look at a single center retrospective study done out of the University of Kansas Medical Center. So essentially what they did is they had roughly 200 septic shock patients. They all got their weight-based fluid. After the weight-based fluid, they were split into two groups. So the usual care group, patients got fluid according to usual care, so if they were hypotensive, tachycardic, oliguric, etc. And then in the stroke volume guided group, patients only got fluid after the weight-based fluid if they were fluid responders. So they had a dynamic assessment done. All the same clinical triggers applied. They were hypotensive, tachycardic, oliguric, but they got a dynamic assessment first and only got fluid if they were fluid responsive. So let's break down the outcomes, look at the difference between the two groups. In the stroke volume guided group, on average, the fluid balance was 1.77 liters. In the usual care group, it was 5.36. So there was a reduced fluid balance overall in the stroke volume guided group. There was a 2.89 length of stay difference, essentially a 3-day less stay for the stroke volume guided group. So it reduced ICU length of stay to get dynamic assessments. There was less time on mechanical ventilation and also less dialysis, so 6.25 versus 19.5%, which is also statistically significant. Only 53% of patients were fluid responders. So again, you're seeing that 50% statistic bear up through the literature. So this was a single center retrospective study. Let's go ahead and see the results of the FRESH study, which was a prospective multi-center randomized controlled trial. So the FRESH study was set up in a very similar way to the KU study. So let's take a look. So as I said, the FRESH study, the fluid response evaluation in sepsis, hypotension, and shock was set up similarly. All patients who had septic shock, they got their weight-based fluid, and then after that, patients only got fluid in the stroke volume guided group if they were fluid responders. One notable difference is that in this study, patients only had PLRs done. So you had your usual care group, roughly 100 patients again in the usual care group, roughly 100 patients in the stroke volume guided group. So the same clinical triggers apply to patients hypotensive, showing signs and symptoms of a perfusion deficit, and before administering fluid, they would go ahead and do a passive leg raise. If the patient was fluid responsive, they got fluid. If the patient was not fluid responsive, they were put on a vasopressor. One of the things that, before I advance to the next slide and show you some of the outcome differences between the stroke volume guided group and the usual care group, is that patients actually over a 72-hour period went in and out of fluid responsiveness. And that's really important for us to note, that dynamic assessments or fluid responsiveness is itself dynamic. What does that mean for us? That means that when you consider an approach like fluid stewardship, you really are going to be, as long as your patient is hemodynamically unstable, because by the time your patient comes to ICU, they've already gotten, usually, some fluid. I think we can mostly agree with that, right? I'm sure there are exceptions to the rule, there always are. So if your patient has already gotten boluses of fluid and they're in a refractory shock state, then that 50% statistic applies from that point forward. So when they're hypotensive, fluid has a 50-50 shot of increasing their cardiac output. And the only reason to give a patient fluid is to increase their cardiac output. Otherwise, why are we doing it, right? And in fact, giving fluid to a non-fluid responsive patient has been shown that it could lead to volume overload. So, which we already know causes harm. So really the invitation here, when you look at a study like a prospective randomized controlled trial across 13 separate institutions, that really validates that a dynamic assessment helps you make a more informed decision about fluid dosing. What you have to know as the nurse is that it will change the way you are approaching your clinical practice, in that you would be doing the dynamic assessment prior to the administration of further fluid, which would somewhat change your workflow. And I'm just telling you that in full disclosure because it might change how you set up your day if you wanted to implement dynamic assessments throughout your shift. So let's go ahead and take a look at the outcomes. All right, so similar to what we saw in the KU study, we saw less need for renal replacement therapy, less need for mechanical ventilation. The other endpoint, because I could talk about more, but the other endpoint that I want to talk about is that more patients were likely to be discharged home as opposed to skilled nursing, which is really, really powerful if a patient doesn't have to go to a skilled nursing facility. So again, this idea of adding a clinical parameter, of adding a way to become more precise with your fluid administration, which fits very well into the category of, or the paradigm approach of fluid stewardship, is very exciting because you can actually assess to see if your patient's a fluid responder before administering further fluid, and we know that that approach does change outcomes for our patients, which is why we're here. All right, let's go ahead and talk a little bit about fluid duration. So you've got your initial fluid resuscitation, which is critical for the septic shock patient, as is the ongoing assessment of volume need, which we've already sort of alluded to. So dynamic assessments are dynamic. Patients are going in and out of fluid responsiveness, as we've already talked about. So determining fluid or volume responsiveness should continue for the duration of the hemodynamic instability until the patient is stabilized. So if you have a patient on low-dose Levophed that you can't wean, that's an excellent time to do a dynamic assessment. If you're going from 1 pressor to 2, that's an excellent time to do a dynamic assessment when you're maxing on 1 and you're going to 2, and you're going from 2 to 3. If you can't, like I said, wean that pressor, and the patient is just, you turn it off and then they crash again, that's an excellent time to actually do a dynamic assessment. When you think about the Rose model as well, when you think about resuscitation in those early phases and then follow that through, it's so prudent to just continue to be asking, and you're asking this anyway, you're doing this all the time when you're looking again at the volume status of the patient. The vessels, what are they doing in response to those vasopressors, and then the pump function, right? Volume vessels and pump. So the fluid part of that conversation will impact all of those, I call them levers of perfusion, of volume vessels and pump, or preload, afterload, and contractility. You're doing this all day, every day. It's just that before we administer additional, preload to the patient, essentially, you want to make sure that they are preload responsive or fluid responsive. I've heard it said both ways. So duration of the fluid is really very dependent on the clinical picture of your patient. So obviously the timing is everything, but this is not, again, it's being prescriptive here is just not optional, because I don't know what is going on with the patient, their comorbidities, all of those things. That's entirely your wheelhouse and completely up to you. So as I was just talking about, I just want to mention this was the Rose model, the phases of fluid therapy. Again, so you've got your resuscitation, and then you're optimizing the patient. You're stabilizing them. Hopefully they're weaning off those vasopressors. They don't need those anymore. And then evacuation potentially. I really do recommend diving in, reading the article, read the KIND study, read the Bensner study about the 50% statistic. It'll give you a nice global overview of this whole conversation. So recently a 3-hit or even 4-hit model of septic shock was suggested, trying to answer the 4 basic questions in which we can recognize 4 distinct dynamic changing phases of fluid therapy: resuscitation, optimization, stabilization, and evacuation, or some people call it, clinicians will call it deresuscitation. So again, you are doing this anyway, but it is helpful to think through the steps of what you're doing sometimes. Sometimes it could be helpful for you to think about, oh yeah, we're in the resuscitation phase. Oh, right now we're in optimization. What can we do to move to stabilization? And then is evacuation part of this? Does the patient need diuresed? Yes or no? And again, those are conversations you're having with your physician, your APRN, or your PA. But again, the phases of fluid therapy, I think, are just very helpful as a framework or paradigm. Okay, so the last thing we're going to cover is fluid de-escalation. In terms of when to start fluid removal and when to stop fluid removal, testing preload responsiveness may still be useful. Indeed, if no preload responsiveness is detected, it is reasonable to assume that fluid removal will not induce a reduction in cardiac output. On the opposite, positive indices of preload responsiveness might indicate the limit of fluid removal and could even be a target to reach when removing fluids. So the long and short of it is, a dynamic assessment of fluid responsiveness is going to give you an additional piece of information that will help you guide fluid decisions for your patient, giving fluids, maybe removing fluids. And as we approach fluid as a drug and we look at the right dose and we look at the right duration and then we look at de-escalation, that you'll notice that we spent the most time on the dosing part, because trying to determine the appropriate dose or the right dose, which can be just really nebulous and hard to determine for each patient, may be made clearer by adding that parameter of a dynamic assessment. And I hope that that is helpful to you. I hope it's useful to you to know that half the time fluid won't increase cardiac output in response to further fluid after the weight-based fluid is given. And that a dynamic assessment of fluid responsiveness is something that can really help you as you pursue fluid stewardship in the critically ill patient. Thank you so much for your time today. May our hearts stay responsive.